Thank you, and it's lovely to be here. I feel very inspired today. So MDS, more commonly known as multi-department syndrome, but easier to understand as disembarkation syndrome. But I usually refer to it by the initials of the French word, so MDDS. This is a rare neurological condition which affects the balance system. And as the name suggests, this often occurs after disembarkation following a motion trigger. So a flight, a cruise, a bus ride into town. But it can also occur spontaneously or be triggered by other factors. The main symptoms of MDDS are a sensation of rocking, bobbing, and or swaying, often described as the feeling of being on a boat when you're not. It's not quite as much fun as it sounds. Whilst many people experience these symptoms for a short while after disembarkation, I think that there is now consensus that if symptoms last for a month or more, MDDS can be diagnosed. Additional symptoms may include, but are not limited to, cognitive impairment, exhaustion, nausea, ataxia, visual stress, etc., etc. And I tell you about all the things that can affect symptom levels, but we would be here all day. Some patients experience periods of remission, which from personal experience is bliss, but then it's an emotional, physical and pragmatic roller coaster when another episode kicks in. And patients often report feeling temporary remission from the motion symptoms when they're back in motion, for example, if they're on a train journey, but then the symptoms return after subsequent disembarkation. For people who were motion triggered, it is now relatively easy to self-diagnose, so patients are often able to tell their doctors the diagnosis. The doctor's approach may be to look it up, read the relevant research, and do all they can to support their patients. But unfortunately, not all of them are able to do this. And a common response is, I've never heard of it, here, take this drug. To some of us, this feels like drug repurposing for no purpose or being a guinea pig, and not as part of a clinical trial. Worse, it's thought that some of the medications prescribed by inexperienced doctors may make symptoms more severe, prolong episodes, and possibly even prevent remission. But people do get desperate, so I can understand why they want to take the medication. But there is very good news. In the States, Dr. Cha is pioneering one treatment for MDS involving cranial stimulation. Thank you, Dr. Cha. And another, optokinetic stimulation, is pioneered by Dr. Dai and his colleagues in New York. And this is the one I'm discussing today. So we're going a bit off-label, talking about off-label drugs. I'm talking about off-label kit. Ooh. So Dr. Dai's research, it started with him and his team looking back through relevant papers, including those from space flight scientists. So thank you, astronauts. It makes a change from saying thank you, mice or zebrafish. These studies indicated a way to treat MDS by rolling patients' heads from side to side, which is indicated here, sort of, while passing black and white stripes in front of their eyes, which is indicated there. So while they roll the patients' heads from side to side, patients watch a moving pattern of black and white stripes. This addresses hypothesized disturbances in velocity storage in the vestibulo-ocular reflex. So they flicked the switch on MDS by repurposing technology. In this case, a projector and a screen. Oh, and you need a chair as well. Technical stuff. So it sounds simple. Well, yes and no. Other than altruism, there's no obvious incentive for drug companies to be involved, which has had ramifications for funding trials of this protocol. If anyone wants to use it to prove a business model, I'd be very happy to talk to you. There's no way to build in a placebo to this trial. And although the kit used is relatively inexpensive, the treatment can take up a lot of clinic time, and so can gathering the follow-up data. So the researchers face difficulties, but they thankfully have not been deterred. For patients, it's hard to do the risk-cost-benefit analysis of going for treatment. In a current trial in Antwerp, treatment is free, but the travel home could undo any benefits for people who don't live nearby. And the big question is, of course, how effective is it? Unfortunately, there was a lot of media hype after Dr. Dai's initial trial, which over-egged the efficacy of the treatment. And I think the consensus is, amongst researchers now, is that if patients report a 50% decrease in symptom levels, so maybe from a 6 to a 3, this counts as a success. And on this basis, treatment in New York is successful for roughly 75% of patients in the bottom panel, talks about that. Of course, I'm more interested in the 25% it doesn't work for, because that's where we learn from the failures. That was fast. Sorry, I missed you. Okay, it is available in the UK now.
Would you like to say one brief thing about the next slide?
Yeah. The woman in the middle has MTDS. She's a lecturer in anatomy in Australia, and she's just put out a fantastic new survey. So it's an exciting time for us. We do have the treatment available in the UK. It is only available for private patients, so we're trying to get it through to prove that it won't bankrupt the NHS. And again, if anyone has any interesting tips for me there, I'd be very grateful. Thanks a lot.